problems. So to be on time, our academic member, Dr. Survi Sharma.
Dr. Jolly presentation.
Dr. Survi. Sudip, over to Dr. Survi Sharma for the next.
Very good morning, everyone. I welcome you all to Midcuticon. We have a session now on effects of COVID-19 on dermatology. To carry forward this session, we have the moderator for this session, Dr. Jordan Ma'am, who is Assistant Professor of Midcuticon Medical College and has over 28 publications, 4 national level presentations, and her special area of interest are clinical dermatology, pediatric dermatology, dermatopathology. I would now like to hand over the session to Ma'am.
Good morning, everyone, and thank you for your introduction. At the outset, I would like to salute the courage, the valor, and the selflessness of our COVID warriors who sacrificed their lives in serving the society and mankind. I am privileged to be here, and I welcome you all to the brainstorming session of effects of COVID-19 on dermatology. Firstly, I would like to introduce and invite our distinguished speaker, Dr. Deepika Pandhi, ma'am.
Thank you, Doctor. If you could just...
I am presently the Director Professor of Department of Dermatology of Dermatology in SCD University College of Medical Sciences, Delhi. She has numbered a good number of publications, including international and national. She has contributed in several chapters, and her career is glorified with multiple awards and honors. Her special field of interest is pediatric dermatology, STI, connective tissue disorder, and AIBD. Over to you, ma'am.
Thank you for the kind introduction. And thank you to West Bengal State Branch for having me here. It's always a pleasure to be part of your academic activities. So as Dr. Jolly said, I mean, we are living and dealing with COVID-19, so there is no choice. So it's a brief overview of effects of COVID-19 on dermatology, because there has been a plethora of literature in the 18 months that we have lived with COVID. So we'll be talking along these lines. There is a lot more that we can talk about: the impact on our diseases, including chronic diseases, the cutaneous manifestation, the effect of vaccination, of PPE and skin hygiene measures, the impact on practice and education and training. So we all know it started 18 months back when in March it was declared as a pandemic. And since then, there have been 211 million cases worldwide. And India has contributed, due to its population, 15% of these cases and 10% approximately of the deaths globally. So we know the population, but what is very significant is, of course, the iatrogenic immunosuppression that we do cause in many of the therapy that we choose for our dermatosis. And still, despite the vaccines, and most of us, in fact, I hope all of us are vaccinated, but there is no specific therapeutic agent. And the exact extent of, how coronavirus impacts, or the COVID pandemic has impacted skin disease, is still emerging, despite all articles being fast-tracked and there being so much of literature. And the best part is that most of the literature is free. So this is one area where all journals have kept it free to download. But still, there is a lot that we still need to know. So there was a sudden lockdown, went through that. There was great economic deprivation. So the impact of COVID is very clear, but how does it impact us? So we know many of the patients, our OPDs were, closed because dermatology is perceived as a non-essential service. So many of our clinics, our hospitals were closed, because there was always a ready doubt of patients being asymptomatic carriers and spreading the infection. Now, coming to more closer to home, which I'm sure most of us have faced, including in your institutes, that there is a perception of dermatology. So almost the first ward to go is, when it's required for any emergency, any endemic or pandemic disease, is the dermatology ward. So that also happened to us. And so it was given to pediatrics. And even though they had one patient, our 6 pemphigus patients were in the corridor. So these are perceptions, but the reverse is not true. So when COVID management came, we were the first ward to start. So we became a HTU suddenly. So we were all managing COVID. All our residents were doing COVID duties, and some of them unfortunately also acquired COVID, because that was the stage when many of them were partially vaccinated. Suddenly, supply of oxygen was the high point of our life. And we all learned, it's a new skill we've learned, and we are proud of it, something which we missed out in MBBS. We learned how to do non-invasive ventilation and manage the same. It was all worth it. I mean, I really genuinely mean it. It was one of the things that I would always remember in my life. It was really worth it. But what impact it had on our patients with chronic disease, which we actually, most of them we remember because they've been in our follow-up for years. So the moment the lockdown opened, so we got a deluge of patients. I won't say a deluge, but all these patients trickled in who could not reach us. So they came with more severe disease, because not only did they not have access to medicine, we have to remember that they are mostly from economically deprived background. They're dependent on the free medicines that we people provide in our institutions. So they had stopped all treatment. They came with increased deformities, which was actually very sad, with more disability. This was a patient in 2005. She came with a SCC. So for the past 2 years, she had not been able to access. So she came with cutaneous SCC. Complications we can take. Then just taking leprosy as a prototype, because this is easy to follow. So if you see, the cases came down significantly from 68, 86 to 9. So obviously patients could not reach us. And this was when we did a closer sub-analysis, the defaulter rate was 220% from the patients who were on treatment from 2019 to 20, and none of the patients who were on treatment in March 2020 could complete the treatment because the access to MDT was derailed. There was difficulty in investigations, as you know, the diagnosis. Even if you were doing teledermatology, sometimes the patients would, because of economic reasons, struggle with accessing, and it's not even available. Diagnostic and investigative, ability is not there for them. Telemedicine has its limitations because most of them do not have access to technology. If a visit was required, then even PPE was a struggle for many of them. We know many of the drugs that we prescribe have some, recommendations for being careful. So all the chronic diseases, there was a concern. Many of them, on the advice of friends or some, pharmacy person, stopped their treatment on their own the moment they knew that they were on some immunosuppressive. So people are wiser. But significantly here, prednisolone, that was an interesting finding, does not come. So they all continued prednisolone in whatever dose they could take, but they stopped all the other medicines. And that was one of the contributory factors for them coming with flares. So the significant thing we all have now learned is that almost all the immunosuppressive agents have a risk of increasing, if not the acquisition, at least the severity of the COVID disease in case the patient comes in contact. So advanced shielding is recommending for them. And that, as we all know, is not usually very feasible in our patients who we have a dense population and very small accommodation with overcrowding present in most of our patients' homes. And steroids, even at the dose of 5 to 10 given for 4 weeks, does induce a higher risk of immunosuppression and requires care. So this was an article that we came out, which, just general points. What is the severity of disease, primary disease, the immunosuppression status, whether they've already received, for example, rituximab, associated comorbidities, occupation, household status, whether, if the patient can isolate, but the relatives cannot. So it's still that they act as bridge of infection, whether they require, some care, they are not capable of self-care, teledermatology consultation feasible, or if they have had a contact with COVID. So these are the general points we would have to see when we consider initiation of immunosuppressive, and of course, the general prevalence of COVID in the particular area, because we know we have endemic areas. So very significantly, this also depends on where your patients are coming from, because people from Delhi, there was a lower dropout rate. As you see, only one defaulted, but people from outside Delhi who are coming mostly from, UP, there was a very high defaulter rate because, as you know, the borders were closed. So these are the problems, and we are likely to now see all these people coming back with reactions. In fact, unfortunately, we know some of them, in fact, had mortality also. Their relatives did inform us. So we, in fact, started teledermatology to a great extent, trying to retrieve some of our chronic patients. We are doing it in our clinics also, as many of our practitioners and even big institutions have started this teledermatology practice to decongest our OPD. And this was aided, in fact, by the teledermatology guidelines being gazetted in May 2020 with clear-cut guidelines for practitioners. So with this teledermatology, we did retrieve at least 8 patients of reactions, because it's very significant. They overnight stopped prednisolone and they did not have access to thalidomide. As we all know, thalidomide is an expensive drug. So overnight they stopped their thalidomide, and some of them even steroids, with their, of course, obvious complications. So beyond hurdles in patient care, let's talk about the varied cutaneous manifestations, which can be the skin involvement, the adverse reaction to PPE, and the adverse reaction to skin hygiene measures. So this was one of the initial studies where they saw 20% of the patient had cutaneous manifestations in Italy, where they described erythematous rash, urticaria, and chickenpox-like vesicles. Subsequently, from Spain, in a larger series of 375, they classified into 5 variants: maculopapular, pseudochilblain, which we all have heard of, urticarial lesions with other vesicular eruption, and livido or necrosis. A further paper from Italy reclassified it as urticarial rash, confluent erythematous macular, herbiliform rash, papillovesicular exanthem. In fact, I find this term more descriptive of what we actually are seeing. And chilblain-like acral pattern, also known as COVID toes, livido or vesimosa-like pattern, and vasculitic purpuric pattern. So these are the descriptive, pictures of the same, and of course we know the sites with which they can be seen. The maculopapular lesions, of course, are more atypical as compared to other diseases. You can see PR-like, you can see EM-like. SJSN10 has also been reported, as well as psoriasiform type of lesions may be associated with moderate disease and during the course of the disease. So this is pseudovesicular lesion and targetoid EM-like lesion, vesicular lesions, and urticarial lesions. Now, what is the diagnosis here? We all have faced this. There was an upsurge in teledermatology with all relatives and friends sending. Most of the pictures were, of course, suboptimal. This is a better quality picture. So here, obviously, there was an interesting debate whether this is herpes zoster or this is the papillovesicular lesion that is seen with COVID. And in fact, both ways it has been recommended, with many people recommending that you should actually do a culture from the vesicles, because atypical localized lesions have been seen with COVID. So this is a very interesting debate. And in fact, due to the immunosuppression and in fact, due to dysfunction, even increased herpes zoster has been. So that makes our life more complicated. And as we all know, culture is not usually feasible for most of us. So many of us would opt for a therapeutic trial. So this is a rash, and interesting purpuric flexural lesions have been described in this patient with normal coagulation profile and platelet count. Another significant is because the other endemic diseases have not gone away. So there can be confusion with dengue. So you've had concurrent infection, you've had mistaken for dengue and vice versa. Recently, in one of the WhatsApp group, I read that somebody died with swine flu because that was misdiagnosed as COVID. Because, it's like we see a monster every fever, we think of COVID. Can have lividoid lesions, especially in older individuals with occlusive vascular disease and with more likelihood of more severe disease. Of course, the pseudochilblains, it affects the acral in younger people. It can be found a little or later after the disease. And it is associated with less severe disease. So it looks worse, but is associated with less severe disease. So these are the clinical examples. It can be the erythematous, edematous variant, or can be presenting with the blistering that you see on the right side. So chilblain-like lesions have been reported more from Europe. The etiology is not known, whether it's autoimmune, hematological, or direct due to infections that induced by COVID, or a combination of all these. Because there's no history of exposure to cold. It can be associated with pain or itch. The dermoscopy, you see the classic erythematous edematous lesion with a coppery red background associated with dotted vessels. You can see erythema mainly on edges. So a dermoscopy can help you diagnose, because most of the COVID manifestations we are not subjecting to biopsy. The red half moon sign has been recently reported. It's a sign of, again, the slow, peripheral circulation and occlusion. So in our series we had a series of 43 patients in our ward, and out of that, this was present in 14 patients. So it's a pretty common finding if you look for it. This was just a summary of all the articles. Interestingly, all were from Europe, and this study is from America. So as you see, the commonest was chilblain-like lesions in Europe, followed by maculopapular, and followed by a varied variety of rash. So COVID does have a very diverse cutaneous manifestation and presentation. So the incidence has varied from as much as 20%, and the commonest findings are, of course, like we said, maculopapular. This is the several studies that have come up. Poor presentation is the most common, with more than 53%, as well as more than 30% present with 37.3% present with a delayed COVID. So that is what is very important. Many times I've heard dermatologists saying that you don't see cutaneous, because sometimes the cutaneous manifestations may be occurring after the patient goes home. So you would get them on your teleconsultation rather than in the ward. So the viral exanthem like papillosquamous and perifollicular rash is due to the initial CMI. The chickenpox-like or zosteriform are due to the viremia. Lesions like ovoid feet, livedoid, and vasculopathy are due to small medium vessel occlusion, as also a more heavy immune complex injury due to or reperfusion injury presenting with chilblain-like lesions. So these were patients that sent me teleconsultation. So this is post-COVID, they were at home. So you can see the vasculitic rash and the livedoid pattern and the racemosa-like pattern in these patients. So this indicates that they have a severe disease, and indeed they had in all the procoagulants were increased. So they required heparin and other interventions. Again, another thing that we have increasing, in fact, our pediatrician friends are increasingly seeing. So this was a patient of itchy, blanchable, maculopapular and urticaria present in a widespread distribution, including the eyelids. And you can see the conjunctivitis and the strawberry tongue. The papillosquamous, the desquamation over the soles with the erythema. So it was Kawasaki. The patient came in shock and was treated with IVIG and recovered on day 15. So this was reported pretty early, and it is reported as pediatric inflammatory syndrome with COVID or Kawasaki-like condition. And it usually does have a good prognosis in children, but there have been fatalities because as compared to normal Kawasaki, it is said that there is an increased incidence of cardiac involvement in patients with Kawasaki-like disease due to COVID. So that is something that we need to really monitor, and intervention has to be early. Interestingly, pustular psoriasis, which also has an autoinflammatory component, has also been reported, as also ENL. So that is a subject that we hopefully can take up later. We all know that we are seeing more of mucormycosis, and sometimes the dermatologist was asked for a consult like these for 2 patients. Vaccination, urticaria, many of our relatives and friends and patients come with post-vaccine urticaria and other, there have been almost all the diffuse things that we are talking about in COVID. This was in fact a relative who sent in this papillovesicular lesion, as well as with this intense urticaria. So you see the quality of pictures, which is to be expected when you receive teleconsultation. You have reports of FDE, you have reports of infiltrated plaque, you have racemosa-like. So almost all spectrum that we talked about in COVID can be seen post-vaccination. So there are several unknown facts, especially from India. So we have a IADVL COVID registry. So I request everyone to please send in your cutaneous manifestation of COVID, it's an anonymous, unlinked kind of a registry. We also have adverse reactions to PPE. So
Ma'am, sorry to interrupt you in between the excellent presentation, but we are running short of time and I think we are bound by the timeline. So, madam, please.
no problem. Okay.
Okay. Now, madam, you can continue, but I would like to request you to wind up within 5 to 10 minutes, ma'am.
No, I'll wind up in 2 minutes.
Okay, thank you, ma'am.
This is due to hyperhydration, friction, we all know, and contact and pressure urticaria. So this all has been reported due to PPE and personal hygiene measures. We all know about the pressure injuries. One of the most persistent complaints that I've come across is acne. So a lot of people presenting with acne to us, as also contact dermatitis, more than contact dermatitis, we are seeing a lot of new onset acne. You see the pressure, I think this is from our ward, our resident. You all know about the increased, hand dermatitis. This is again teleconsultation, all friends and relatives sending in these kind of pictures for consultation. So moisturization is the key message that you need to give to them, as also other precautions, like whenever they can, they offload the mask or other PPE and hydrate their skin, both by drinking water. So these were all the guidelines that many of the SIGs came across, as also the Board of Governors guidelines for teledermatology. So please go through them and apprise yourself and keep yourself updated. So we have had a lot of impact on our practice. So we have some, I think we'll take this up during the panel discussion. And of course, the last image that I would like to talk about is that all teaching has been virtual. So I am the iPhone, and we have had it a great way of interacting, but of course you cannot actually see and feel the patient, which in dermatology we all love to do. We've had a lot of learning activities online. We've had new platforms. So the positive thing is we adapt very well, but we would like to go back to where we were. So to conclude, we've had a great deal of impact on almost all aspects of dermatology, whether it is providing healthcare to our patients, diagnostic and management, our practice, our uptake of teledermatology. I think that is one of the most positive outcome of this COVID, as also the virtual education and training. We need to keep abreast with the cutaneous manifestations, because many of our patients, we would be looking to tell them whether they could have the COVID or not. So thank you. Let's keep up web-based interaction, hopefully even when COVID goes away. These are my acknowledgements. So I have not exceeded too much my time.
आपको वेलिंगटन जाना है? वेलिंगटन।
Dr. Jolly, you are muted.
At the panel, or should we are studying the Kaushik Das thing? Let decide. Shamita, what you are wanting?
Should we start the panel discussion?
Kaushik Das ready or not? Chale, we can finish the panel, then Kaushik Das in between the session, whatever you like. I don't know. Kaushik Das, acho?
Sir, what to do?
Kaushik Das.
Please proceed with the panel discussion. Jolly,
Okay. Thank you, sir. Thank you, sir.
please proceed with the panel discussion. We will complete this session.
Okay, thank you, sir. And thank you, ma'am has excellently covered all the aspects of this topic, and she has addressed some of the most important, interesting and practical issues in her initial slides. I feel privileged to introduce our speaker, panelist of this session. Our first panelist is ma'am, who has been already introduced. Our next panelist is Dr. Sudeep Das sir. Sir is presently the professor and HOD of National Medical College, Kolkata. His career is glorified by several awards and auditions. Our next speaker, panelist is Dr. Sanjay Rathi, sir. Sir has around 30 publications. He has presented in many national and international conferences, and he has contributed in several chapters. And his special field of interest is clinical dermatology, pigmentary disorder, and acne. Our next panelist is Dr. Shomo Panda, sir. Sir has several publications, and again, his career is acclaimed by several awards and honors. His special area of interest is evidence-based dermatology and clinical dermatology. And last but not least, my mentor, my guru, Dr. Professor Qubix sir. He is presently the professor and HOD of Bardwan Medical College, from where I do belong. And his special field of interest is clinical dermatology and dermatopathology. As ma'am has said, this is surely once in a lifetime unprecedented crisis situation. And despite the emergence of new data, we are still facing some problems regarding the clinical codes and prognosis of the disease, and same holds true for the dermatological manifestation. Today we will discuss the topic. Are all the panelists are here? Sir, Dr. Sanjay
Yes.
Rathi, sir, Dr. Shomo Panda, sir, all the panelists are here, sir?
Yeah.
Okay, thank you, sir.
Yes.
Today, we will clarify our some queries and doubts regarding COVID-19 on dermatology under these sections like cutaneous manifestations, dermatological condition related to COVID, therapeutic consideration, delivery of care, and COVID vaccination in the background of immunotherapies. As it has been reported, the prevalence varied globally from a prevalence of 0.2% to 20.4%. Now, my first question is to Deepika Pandhi, ma'am. Ma'am, how will you explain these differences in prevalence across the world? Ma'am, what is your opinion in this regard?
Well, I think that, in fact, there have been debates on this. I've heard some debates. The issue is that I do not know how much it is, difference in prevalence rather than difference in documentation. So many times in India, we might not be, like I told you, many of the cutaneous manifestations come late. They do not come during the acute viremia while the patient might be in the ward. So the follow-up in our patients, as you know, in India is very, very suboptimal. Whereas the more, European and US have a better system of, follow-up. They have access to teledermatology. So the patients that I showed you were teledermatology. They were not walk-in patients.
Okay, thank you, ma'am. What is your take on this point, Dr. Panda, Shomo Panda, sir?
Well, as basically clarified by Dr. Pandhi, I think it will be not possibly wise to speculate on the reasons behind the differences in prevalence, because the figures on prevalence, it is very doubtful how much reliable those are. It is the situation, I think, across the world, whether it is China or India or even the developed countries. One problem is inherent. That is because most of the, or quite a significant percentage of COVID infections are asymptomatic or the so-called pre-symptomatic infections. That is, they're not clinically expressed. They might never be clinically expressed, or when the testing is done, even if the testing is done, first of all, even if they are positive, they might not show the signs of COVID, or vice versa. Even there are false negative RT-PCRs, which is quite well known. So all these are the inherent factors, and then the logistic factors. In many parts of the developing world, including in our own, there is this great challenge of documenting the condition, particularly in the absence of serious population-based surveys and all. And because of this, I think that might be a reason why, because mostly the data that we have in case of India, for example, mostly institutional data, where the people have volunteered, right? And rather than the other way around, where the health workers go from house to house, because that is not feasible in our setup. So because of all these things, I think there is this difference in prevalence.
I just like to add one more point. All the studies that we were talking about are multi-centric. The ones that I showed, 700. The latest registry is 700. So that's also not a huge number. So the idea is that that's why for a disease like this, where there is, there are barriers. So you would need registries. So unless you have registries, at least that's the beginning of getting more data to make any kind of opinion.
Thank you, ma'am. Thank you for your this opinion. And I think another one issue is when the initial studies were done in China, at that time we were more concerned about saving the life and the respiratory symptoms. We are not quite acquainted with the cutaneous symptoms. Nowadays, we are coming up with, we are being oriented with the dermatological manifestations of the COVID-19. That might be also an issue, and initially the cutaneous manifestation might have been underestimated. Now, ma'am has already mentioned about the cutaneous manifestations of COVID-19. I would like to ask Professor Kaushik Shomsar, sir, what is your experience regarding the clinical patterns, and is there any difference in our setup as we have found in the literature? Is there any difference in the relative frequencies of different medical cutaneous manifestations of COVID-19?
Good morning, Jolly. Yes. Am I audible, Jolly?
Yes, sir, you are audible.
Okay. Actually, we have recognized there are 6 patterns of main patterns of clinical presentation. As ma'am already mentioned, this is the exanthematous type and the articarial one, and the papillovesicular eruptions, as well as there is chilblain-like lesions. And one is the vasculitic type and livido-reticular. But in our setup, what we have noticed that the articarial one is the main presentation, and followed by this maculopapular rashes, and the vasculitic pattern we have not very much seen in our setup. That is the main thing. And in case of children, the presentation was different in that they usually present with this articarial rashes and chilblain type, as well as there is Kawasaki-like presentation, where there is mucositis and stomatitis, as well as the formation of the palm and so. And also, in case of Kawasaki type presentation, we have noticed the involvement of the GI symptoms was there, much more, and cardiac manifestations were there. And the marker, there was increased very much, and as well as there is in blood count, there is a neutropenia and thrombocytopenia. The chance of myocarditis was there very much.
Thank you, sir. Thank you for your opinion. And I would like to request the other who are not actually participating in this session to unmute their laptop or devices. I just want to ask Dr. Sanjay Rathi, sir, what is your experience in your practice regarding cutaneous manifestation? How often have you come across, and if so, where you, in all these cases, the cases where COVID-19 positive, you came across the post-COVID symptoms, or you first you put the diagnosis, then you suggested COVID-19 test and it found to be positive? What is your experience, sir? Dr. Sanjay Rathi, sir.
Yeah. Here again, basically the reporting is a real problem. So basically a prevalence, what we are seeing, it is a Western literature. In Indian scenario, only the research center, medical colleges where we are finding that COVID patients are admitted, there only we are getting these sort of lesions. So maybe in an acute phase of a COVID-19, they are more concerned for the other systemic manifestation. Later on only they are coming into that there are some clinical manifestation is there on the skin only. So definitely this prevalence basically may not be true for our Indian scenario. I mean truly a clinical practice. What I have noticed, I can of late recall only 3 patients of mine presented with the urticaria to whom I can diagnose seeing the urticaria for a COVID-19. Actually, the patients presented to me, asymptomatic patient with urticarial rashes. I just inquired that is there any history in their family members having a COVID-19? They could come out that maybe 2 to 3 weeks back they had one. Then I've asked them to do a RT-PCR test and it has come out to be a positive. So sometimes a asymptomatic patient can present as a cutaneous manifestation, but I can count only urticarial rashes in my clinical practice.
Thank you, sir. Thank you. Now, my next question is to Dr. Sudeep Das, sir. Sir, what do you think? Are these manifestations of because of direct viral invasion or this is a paraviral epiphenomenon?
It is a mixture. Firstly, wherever they affect the endothelial cells, whenever the endothelial cells have ACE2 receptors, wherever you have ACE2 receptors, there will be direct endothelial effects, and there we can have that vasculitis type of reactions. And apart from that, the paraviral phenomenon, the remote vascular or the immune phenomenon, the activation, that is also a part of the both the procedures. So it is a mix of the both. It is not a single isolation phenomenon. It is more complex than what we think. Both direct and as well as indirect are parts playing to role.
Exactly, sir. Both the phenomena are working side by side. In continuation with this question, one term we are coming across daily again and again in the social media and the news, that is COVID-2. Is there any actual causal relationship? Because in most of the cases we found that the RT-PCR was negative and only in minority of the cases the serology was positive. So how to explain this condition?
Can I take the COVID-2 actually is mainly found in the children, and COVID-2 is not a serious manifestation. It has been found in the mild COVID cases. And what has been seen in the COVID-2 is that most of the patients had recovered by 3 to 8 days. So COVID-2 as a whole, yes, it can occur as a part of chilblain-like reaction on the toes, mainly in the acral part, and that has been seen predominantly in the children. It has been reported, and also in the adults. Some adults have reported, but mainly in the children. And regarding the fact is that it is not a serious manifestation. The more serious manifestation, there is some manifestations are associated with more serious manifestations. The first is that if you have a retiform purpura, if you have a
coming to that question, sir, I'm coming to that question on my next slide. Sorry, sir.
The previous part question which I want to react is that regarding what Dr. Rathi responded is that it depends on what type of institution you are attached to. If you are an institution where a lot of COVID patients, then you can find more of chilblain and all this type of vascular reaction. If you are purely into the dermatological practice, then you will find urticaria as the most manifestation.
Thank you, sir. Thank you. Very valid point, sir.
Yes, sir. May I add something?
Yes, sir. Definitely, sir.
I think in chilblain-like reaction, there is a increase in the interferon 1, I think, and that will lead to the rapid viral shedding. That is why I think RT-PCR is negative, and most of the cases, as well as in the RT-PCR, the diagnostic tool that was used during that time, that maybe was not very much sensitive. That may be a false negative result that leads to.
Kushita, there was a very important study very recently on skin biopsies in COVID patients. And there were 63 skin biopsy patients. And what has been seen that almost 61 of them had turned to be the biopsy samples were negative when tested with RT-PCR for COVID. In fact, vesicular rash, which was reported, Dr. Deepika has very rightly mentioned that. And that fluid was itself was RT-PCR negative. So RT-PCR has got nothing to do with these manifestations.
Thank you, sir.
In COVID positive, we have 66% positivity.
Sir, regarding the specific versus non-specific cutaneous lesion, is there any validated criteria? Anyone can take this question. As we have seen several types of cutaneous manifestations, but is there any criteria to classify them between specific and non-specific? Any one of you, sir, ma'am, can take this question.
Yeah, if I may take up this one, I think, is there any specific cutaneous manifestation of COVID at all?
That is a question, because in most of the studies done previously, it had mentioned there is no such specific or accurate marker. Because
Absolutely. That is the problem. That is the problem. basically, if you look at the kinds of lesions which have been reported in the literature the world over,
Yes,
there
sir.
is not a single lesion which can be said to be specific to COVID. Even the COVID toes, which was thought to be a very atypical and a sort of a specific lesion at the beginning. I mean, then it came to be known as chilblains, then pseudo chilblains, and nowadays it is being termed as a much less dramatic acrodermatitis kind of lesions, simply because the lesions themselves are much more polymorphous and much less specific in their appearance than something to be labeled as a chilblains or pseudo chilblains, let alone COVID toes. Then comes the question of the association. I mean, if we have to associate two clinical conditions, I mean, as in a kind of a short-acting pandemic, short-acting means individual cases are short-acting, that is COVID-19, with some clinical manifestation as COVID toes, you have to do, epidemiologically speaking, some very well-controlled case-controlled studies. I mean, there is an absolute lack of that.
Definitely, sir.
That is very unfortunate simply because I do not think that there is any specific manifestation of COVID at all as far as dermatology is concerned.
Thank you, sir. Very well mentioned, sir. Now, as we are discussing the cutaneous manifestation, ma'am has already described what is the prognostic significance of skin lesion. I'm not going into the details of that. Now, some practical questions. I would like to ask Deepika Pathi, ma'am, what is your experience on post-COVID skin manifestation? How frequent these are? And one problem I am facing great challenges in dealing is the telogen effluvium, hair and COVID. What is your take on these points, ma'am? And how to tackle these patients?
Basically, like I told you, we've been managing COVID wards. We saw COVID manifestations in our ward, as well as we got teleconsultations, because as we settled down after the shock of the second wave, we kind of got used to doing teleconsultation for inpatients. So we did see, but what was more surprising was that we got a lot, like I told you, of teleconsultations for post-COVID skin manifestations, people who went home. And what we have to realize is there is something known as long COVID, especially in older and people with more, risk factors. They need to be put on some anticoagulant long term, especially who had very bad markers, biomarkers during their acute COVID. So you need a follow-up, and that is something you must tell your patients. And skin manifestation here, what we talked about earlier, may be an indicator that they need to go back and continue their anticoagulation, go back to their chest physician and get a reevaluation. Both the patients that I showed you did have very deranged values. So post-COVID skin manifestations beyond the hair, I think the other skin is there. We see vasculitis, we see racemosa, we see livedoid, we see almost all. And anagen, and we see not only hair, we are seeing post, mucor is one of the, actually, if you say even including post-COVID, you are seeing increased dermatophyte because the steroid and all, you're seeing all the chronic diseases being complicated. There is a debate about psoriasis also. So it's a huge spectrum. So like Dr. Panda said, we have less data, but that is to be understood because it hit us so hard. There was no time to think about what is happening in the skin, frankly speaking. So it's only now that data is emerging. Most of the data that we are talking about now is from the second wave. It is not from the first wave. Right? So that is when we could, whether it was more or because we had got used to teleconsultation, again, a matter of debate. Now, this is actually not only telogen effluvium.
Anagen effluvium
has been reported. So that is the interesting thing. It's like total anagen effluvium, severe. So that is also, so it can be both anagen, telogen. If the patient has walked in, put in your dermoscope. Mainly, management as per any telogen, but you do a blood count. Many of them turn out to have some hematological compromise also. So as compared to other people here, the only suggestion would be to do a blood investigation rather than just begin treatment. The treatment, of course, would be more of hand-holding because they're presenting now. It is 3 to 4 months after second wave.
Exactly. Since last 1 and 2 months, they're presenting with this problem.
April and May. So from August onwards, there's a barrage of
Yes.
we are presenting with the effluvium, with the
Effluvium.
we should evaluate. So this would need, we need to also remember other conditions beyond hair loss.
Definitely, ma'am. Then I would like to ask Dr. Sudeep Das, sir, is there any increased incidence of herpes zoster in the setting of COVID? What is your experience?
Before I will also take this, and I will also want to comment on the telogen effluvium part also. First, taking your question of herpes zoster. Yes, there is an increase in herpes zoster, obviously in the setting of COVID, but few of the cases need to be evaluated whether they are varicella-like rash of the COVID itself or it is a herpes zoster per se. Now, regarding these, we carried out a case of series of 3 cases, which I have already sent for publication. I don't know what the results, it is not yet accepted, so I'm not commenting on that. The only thing which we found is that what the zinc was negative in each of the 3 cases we did, firstly. Secondly, the RT-PCR regarding the COVID cases was positive in only 1 out of the 3 cases. That is the report that we found. So in many, what we have tried to search the literature, what we found is that varicella-like zoster COVID presentation, they actually come more of, they have more of truncal involvement, they have pruritic in nature, and they are less inflammatory compared to the herpes zoster lesion, but herpes, this varicella-like reaction. That is the other things that we found in the important. The 3 cases which we found is that, so there can be a case where you have varicella-like presentation in case of COVID. That is one part. The other part regarding what is important, these are both anagen and telogen, because in 2-3 cases I had already done cut the hair and examined that, and we found that it is not only telogen hairs, there are also anagen hairs. First, the second thing is that what I found a strange association. I'm following it up and yet not to comment on it because vitamin D levels are definitely low in most of the cases post-COVID hair loss. What I found is that out of 50 odd patients, what I'm finding is that there are almost a 30 patients with vitamin D loss. But how much that is significant, because COVID patients are reported to affect more with lower vitamin D. So that can be an association. But whether this is an association or is a finding, I need to evaluate that. And second part I found is that I want to know more from the panelists. The 2 or 3 cases of my on stable psoriasis had exacerbated despite on treatment on immunosuppressives with COVID. So has anyone experienced that? Pityriasis like
run out of
like rash has already been explained.
Sir, we have to complete the session. Actually, we are running out of the session. We can take the session question later on. Here are some other questions, like I am just going into some important one. If a patient comes to your clinic or OPD with an episode of first-time acute urticaria or PL-like lesion, what will be your step? Will you suggest for COVID test in all these cases?
Charlie, can I answer?
Yes, sir, definitely, sir.
If the urticaria is associated with myalgia and like that, the other viral symptoms, or if it is associated with other loss of taste sensation and anosmia, I think, there is a family history of COVID contact patient, we can do RT-PCR in that cases.
Okay, thank you, Jolly.
Because that might be due to the COVID presentation.
Sir, just one important consideration regarding, I will stop my panel discussion after this. Sir, sorry to interrupt you. One practical is regarding the immunosuppressive therapies. Ma'am has already mentioned regarding the different bodies, IADVL, Academic Code, SIG, all have mentioned regarding the guidelines for immunosuppressive therapies. Sir, what is your practically what will you suggest to your patient in the clinic or as if one patient of chronic plaque psoriasis is on immunosuppressive therapy and the patient is two conditions. One, the patient don't have the active infection, but he belongs to an area where it is a high risk area, and another when the patient is having presumed or confirmed COVID-19.
The only take-home message I would like to give here is we cannot adapt the Western guidelines.
Definitely, sir.
Don't live like that. So that we have to remember. So while it says that do not stop your immunosuppressive therapy, 2 messages: switch to a more safe option if possible. 2, reduce the dose. 3, advise shielding. Like if you've received a patient has already received rituximab. So then you need to really guard the patient and shield the patient, reduce the steroid to minimum effective dose, supplement it with topical therapy. For example, if it is psoriasis, you may choose acitretin or apremilast, which are safer. You may use the alternative therapies more. So the message is that as far as possible, you avoid the drugs, especially now there's a concern a little bit with methotrexate and a little concern with cyclosporin, even though theoretically cyclosporin, if you go through the literature, it says that there was no impact. That suppresses influenza and other older coronaviruses. So, but theoretical versus what actually happens, they do increase the severity of the disease. So
what about vaccination?
I'm coming to the next, the vaccination. So that means the conclusion, when take home message, so should we continue the immunosuppressive therapy or we should discontinue it?
Jolly, can I
discontinue
one
it?
word? There is a recent article in IADVL in April 21, which clearly states that except for rituximab, you need not have any caution. And only in severe COVID, you should have a caution. Regarding the vaccinations, they have told yes, because it reduces the immuno response. You can definitely tone 7 days before and 7 days after. You can stop the vaccinations in part. You can just ask them not to take. But regarding others, you can go ahead.
That is what I was telling. Their recommendation.
I agree with that. Deepika,
That may vary in our setup also. And Dr. Rathi was willing to add something, sir. Dr. Rathi, sir,
No,
you are willing to add something?
No, everything has been spoken and we are running out of time also.
Yeah, I will just take a few seconds to make just a couple of points.
Definitely,
One is, it is very difficult to take a clear-cut view about the immunosuppressives, because as Dr. Pandhi had shown her in her presentation, prednisolone is supposed to worsen the possibility or the severity of COVID. And as we know, prednisolone is, or steroids are, life-saving in severe cases of COVID. And similarly, very recently, WHO has taken up infliximab as one of the agents in which it is investigating as a treatment of COVID. So already the trial is on. So the situation is very fluid and dynamic. And so we should be, the best thing we can tell is we should be studying a lot and keep our ears and eyes open and just take a look whatever is happening all around the scientific world. Every day.
Okay, Dr. Pandha, we understand you, and Dr. Jolly, thank you very much. Just say thank you and just end this session.
Thank you, sir. Yes, sir, thank you. We have all enjoyed the enlightening panel discussion. I would like to thank Team Midcuticon for giving us this opportunity, and thank you all the panelists for your expert opinion and advice. Thank you, sir.